All right, excellent. We're here with Brian. My name is Eric Leafgreen. Brian, thank you for joining us today. Fellow board member on the AAPCP. What a journey we've been on. The first year had 100 people at the conference. Now we have 350 people. Amazing work. So congratulations on all the hard work that you've done with the board and growing the organization. So we're going to kick things off just casually. How did you get into physician compensation? What was your first job in this space?
So I have a strategy background. I started in strategy consulting and then went in-house with the health system, and we had just acquired a lot of different practices at once that had different operating models, and we were trying to bring some consistent standards to the group, but we realized that we couldn't have clinical alignment without economic alignment. So that was really my first foray into physician compensation, was designing a primary care model that kind of aligned the needs of the health system with some incentives for the physicians. So we looked at things like panel size, quality metrics, patient sat, work RVU levels, and I just became very interested in the field of provider compensation because it blends so many different disciplines at once. It draws on strategy, legal and compliance, you have to have a deep knowledge of operations, and you need to be able to articulate very complex concepts to very different audiences. And I enjoy the variety, I enjoy the importance, and as we've seen with the growth of the AAPCP, this is becoming a paramount strategy for health systems of how do we financially align with providers and kind of row in the same direction. So it's been a rewarding journey. Like many of us, I kind of got into it on accident, tangentially from other work products that kind of brought to light how important a solid primary care compensation formula is, or with any specialty really.
That's I love that story there. 2 points really stood out to me. One was financial economics of it. So many times in this space, you hear about survey says, your team took a different approach, economics. And then the other piece is kind of that softer skills. How do you communicate these complex folks to a physician executive, to an operational leader there? So it does require a lot of different skill sets. With that though, what does your family think you do? So how did you get into it? But I know my family is always like, I have no clue what you do. It doesn't sound like a real job. They probably don't think I actually work. But what does your family think you do?
So, funny story, my three-year-old at the time swallowed a quarter and was very upset. We were driving to the emergency room and he was crying the whole way. He said, I don't want the doctor to yell, I don't want the doctor to yell, I don't want the doctor to yell. I said, the doctor's not gonna be mad at you, this was an accident, this happens. He said, well, the doctor's not gonna yell at me. I always hear the doctors yelling at you. So that what they think I do for a living is basically argue over money, which is very far from the truth. But I think they, are just by osmosis or exposed to some of the, high stakes, emotionally charged conversations that sometimes accompany this role.
Excellent. So I know you recently took on a new role and have been there. What has been one of the biggest challenges as you onboard to a new group and with so many complex, important functions that you do? How do you get settled in? How do you identify the priorities in your organization? So what was the biggest challenge for you?
I'd say becoming familiar with the various data sources that are in place. I work for a health system that has a few different legacy medical groups that are all coming together. And there's different data resources availability depending on which legacy medical group you're working with. I think it's really important to understand the different cultures of different medical groups, from where the physicians came from, kind of the history of how they've been paid in the past, making sure that everyone has a voice at the table to have strong input in the future. I don't think any compensation formula or large-scale change will be successful without buy-in from the physicians. So being a newcomer, you have to establish trust very quickly. You have to establish credibility that you know their data in and out, especially when it comes to compensation. You have to very quickly get an idea of what the near-term and long-term strategic goals of the health system are, and kind of gain consensus as to how we're going to get there and a roadmap together of how do we align the financial and strategic and quality goals of the organizations with how we relate to providers economically.
Excellent. That's a very high-level strategy. When you came in, did you have to build a bigger team? Did you have to get more resources there? What did you do to advocate for those resources?
So, like many organizations, provider compensation sometimes tends to live in different departments across the health system. Some, it may be managed in human resources, others it may be managed in finance. When I joined, we transitioned from finance to operations. So it was kind of level setting of what former financial tasks that were on the plate of my team, who was used to reporting up through finance, what kind of legacy, more financial planning and analytics functions can be offloaded to others so we have more bandwidth to really focus on provider compensation. So
Excellent.
That's a big transition. We're working through resourcing and what other areas of the health system make sense to centralize within a centralized
That's cool.
provider compensation.
That's a good story there. That's always challenging coming in, build new resources, change management can be tough, especially as you come on to a group. One last question. If we look forward, I know many of us are not in the prediction business, but where do you see this industry looking like in 5 years from now?
I think we're starting to see the beginning of the physician shortage. There is a growing mismatch between supply and demand. There are certain specialties like anesthesia or pulmonology where majority of that workforce is over the age of 55. So very concerned as how are we going to have sufficient knowledge transfer from our most experienced, senior, seasoned physicians, many of whom may elect for early retirement because of burnout and frustration with kind of the overall care delivery system. So I think we're going to start seeing that shortage more and more. I think we're going to need to get more creative with how we experiment and leverage and operationalize care teams. How do we allow our APP colleagues to practice at the top of their license? How do we, build an infrastructure around a grain population with more complex medical needs that, the needs of, the more chronic conditions, we need to build a infrastructure around that too to make sure we're caring for the right demographic.
Yeah, I've been hearing about that a lot with certain the aging demographics in certain markets, but also have a declining population in that area too. And it's really been a high burden on the health systems to make long-term investments while there's not a age or group behind it to help support it. And then definitely see a lot of growth in the APPs. I think I saw some data that Medicare beneficiaries, the number of encounters by an APP has been increasing by 7.9%, I think, a year for the last 5 years. So definitely kind of speaks to that shortage. Well, I won't keep you much longer. Thank you for joining us. We appreciate your time today.
Thank you for having me.